the challenges, I think, as you say, we have on the programme. Castrate-resistant disease this afternoon. It's our first session after lunch. So it's a term that Georgia and I felt, and other people feel, is being used. And it's a term that perhaps patients find out about, actually, when their hormone treatment is no longer effective. And that actually, as you say, is sort of doubles the burden. And patients can put something into Google. So there's patients saying to us, please don't use the word. Everybody here is saying they feel uncomfortable about the language. So how do we approach that? So I'm going to open that up. I know John has some thoughts, but open it up to you for your views and questions. John, do you want to?
Yeah, I'd like to make just a couple of points, if I may. The castrate-resistant prostate cancer is a very specific medical term which is now used generically by everyone, including anyone who talks to a patient. The term came about for a very specific reason. When you use surgical castration or an LHRH analogue, and the patient's disease responded to treatment and then progressed, we used to talk about hormone-resistant prostate cancer. And of course, what's come along is new types of hormone treatment. Abiraterone, MDV3100, you'll hear more about, where the hormones still have an impact. So castrate-resistant prostate cancer defines a very specific group of patients who are still amenable to hormone treatment and will respond to it. And therefore, the clinicians, the scientists, define that group in that way, and then there was the explosion of language and everyone used the term. I don't use the term whenever I talk to a patient because I think it's of absolutely no benefit. We've heard the negative connotations. So I just want to give that as a fact. And the second thing I want to say is I think there's a different way of starting. We talked yesterday about setting patients' expectations before we start treatment. Do you know, I don't talk about erectile dysfunction or loss of libido as a side effect of hormone treatment. I tell them it's going to happen. It's an expected effect. It's not a side effect. It's absolutely predictable. And when you discuss the need for hormone treatment with a patient, you say, this is what we're going to achieve, and this is the price it will come at. And I think if you set that expectation very early on, you achieve much more than not mentioning it, and then the patient complains in a survey, I've got erectile dysfunction. Well, they knew they were going to get that. Third point, and this is like my last point, the first question I always ask before I start any androgen deprivation therapy is a simple one. Are you sexually active? And ideally ask that question when the patient's partner's there. Because if they're not, a whole load of questions go out the window. If they are sexually active, there are alternative forms of hormone treatment, anti-androgens. Okay, Mike pointed out they have different side effects, but they do allow you to have the chance to preserve sexual function in certainly a significant proportion. So there are options. I've said enough. Let me
do we have questions?
I'd like to say mea culpa on behalf of the oncologists. I think this is something that we have done without talking to patients. Because John is absolutely right. We decided that with our new treatments like abiraterone, hormone resistance was the wrong term, and it is the wrong term scientifically. But we decided to impose a new term, and we didn't talk to the patients about the impact that might have. No one ever talks about castration, as Michael said at the beginning, so why do we talk about it when the hormone treatments failed? We suddenly introduced the term. So I think we need to think about something that works both for the scientist and for the patient. And I think, on behalf of my colleagues, I sit on what was the HRPC clinical subgroup of the ETRI, and we changed our name to the CRP subgroup 2 years ago. And that now is the accepted term in that scientific community. But you're right, because of the connotations, I think we've got that wrong. We need to revisit it.
So what do people think they need to do to go back to their healthcare professional teams if you're using this term?
Challenge them and say, why do you use that term? Is it helpful? Is it meaningful? That would be my suggestion. Because I don't use
show of hands about how many people's MD team use the term castrate resistant. So not many. What alternative terms are used then? Hormone.
I know there is a subtle difference about we add in maximum manageable blockades, and therefore when they fail those treatments they then become hormone resistant, but it's just not used. Like you said, there's no benefit to using that term. Everybody knows when they first failed an LHRHA, then that's where we are with it. But can I just ask a point?
Yes, please do.
We're constantly told we're not managing the side effects of hormone treatments as CNSs. All of these side effects that they're getting are normal responses to what we're doing to them. How can we manage them? I mean, it's very difficult to get a man potent when he's on Zoladex.
Well, can I pick that up? If a man expresses or tells you or responds to your questions and you identify that that's something important for them, you're not likely to be able to allow them to develop spontaneous erections, although surprisingly a small proportion of men do remain normally sexually active. But for the ones who don't, really it's more about giving them some form of assisted erection with a vacuum device or intracavernosal injections. So they are able to develop an erection using those sort of techniques and to remain sexually active if they so desire. What's much more difficult is to restore libido, that you can't achieve.
We do a very active service for this.
Ditto.
Most men, after being taught to use the vacuum device, no longer use it. It's too cumbersome.
Yeah.
And many men will not inject their penis. So
Yes, I know.
we're in a situation where the PDE5 doesn't really work when somebody's on Zoladex because they don't have the libido. So to manage it is very difficult.
Which is why I think absolutely John's approach is correct. Patients have to have that expectation up front and the beginning.
Yes.
And
I
then
think
a relatively...
as well, it's not just necessarily the men on their own, it's sometimes the couple.
It's also, I mean, if you're providing support, that's excellent, and from the charity's perspective, that's all we ask. I mean, we do recognise it may not work, or some men may not choose to use it. I think the results of our survey indicated that in many areas across the country, men weren't getting that support or that offer of support and feeling that they were left to cope on their own. And I think that would be our response, that they should know where those services are and be able to access them if they want them.
Can I add something to that? But actually, I think in some cases, and I think it is very patchy, I think for men having hormone treatment, they're an interesting group because some people are cared for very much in primary care. Sometimes they come to the hospital and they're managed more there. Sometimes it's a hybrid between the two. And I think in some cases, the needs aren't actually even assessed, let alone addressed. So we're not necessarily systematic, I don't think. I think it's very patchy throughout the country. In some areas it's excellent, but in some areas actually it is patchy.
I think there is a difference between what we mean by unmet needs, and that doesn't mean that you solve the problem.
No.
So you may not be able to solve the problem of erectile dysfunction, but actually the patient can have a discussion with you, you can assess them, you can give them options, they can talk about the implications and what that might mean, whether they might need counselling or whether they couple themselves. So that's not unmet need. You may not be able to solve the problem. I'm just mindful of time. I know there's two more points. Lady in the red cardigan had one, and John here, and then we might...
My name is Mary from St George's Hospital at Prostate Cancer. You really just touched on what I was going to mention, that like yourself, I find it difficult to, the nurse in me wants to fix it, and I've got patients telling me I've got lack of concentration, I'm exhausted, I'm bickering with my wife all the time, we're fighting, and they're not coping as a couple with their hormone therapy, and I'm really struggling to know what to say to help them. And I'm trying to listen, that's one of the things we should be doing. But one patient said last week actually that they had a road traffic accident. He's got a clean license for all of his life, he's never had an accident before. He started hormones 6 months ago and caused quite a bad road traffic accident. And he's devastated about it. And I listened and I was very upset for them, but I couldn't give him an answer. I couldn't say, well, stop your hormones then.
Except that actually, for somebody like that, I think that's what John was about to say.
Yeah.
We haven't touched on intermittent hormone treatment.
You've got the solutions.
But actually, patients who are really badly affected like that, we do sometimes have a discussion about intermittent hormone treatment. It's not something that we use as mainstream, really. But for patients like that, I think it is very much an appropriate thing to do.
I'd go further than that, Mike. I'd say that you should actually enter into the discussion of intermittent androgen deprivation therapy early on, because the evidence is it's no worse than continuous treatment. If you go straight in and say, do you know you can stop your treatment without any detriment, that would be an incredibly positive thing for the patient to hear, for you to do, and maybe to have a positive impact, and that's a good thing. And in terms of what else can you do, there's good evidence that increased aerobic exercise minimises the risk of muscle loss and fatigue and so on. The studies are coming through that are showing the benefits of that.
Just one last point.
Yeah, just to touch on that point. I'm the helpline manager, and we get a lot of calls actually from elderly men who've been on hormone therapy for a long time, being followed up in the community. And, you know, we mentioned intermittent hormone therapy and that they should go back for review, but they've been on it for years and they have got side effects, you know. They sort of been lost to follow-up really or managed by their GPs. So.
But it's the CNSs who will be there to offer them intermittent therapy early on. Think of it early, particularly if they've got side effects to worry about.
And can I just add that the lack of emotional support is something that men said, and it's not that necessarily CNSs should be expected to provide that emotional support, but that we would like to see services available in every area that men can access for psychosocial support, so specific specialists that can help them with counselling or relationship problems or whatever it may be.
Thank you. Now, I'm mindful we were going to have coffee. I just wondered whether any of you wanted to add a final comment before we go to coffee. Yeah, everyone?
Yes, just to go back to terminology, I would say be very, very careful about using medical language with our patients. And I say that from someone who, my other passion actually is to do with researching fatigue, which I've done about 15, 20 years. And that wasn't a word which patients really understood, and in fact still don't. But yet all our information when we talk about it is to do with fatigue. I don't think it's helpful, and I don't think it's necessarily been helpful in that sphere either, that actually use a word which is unfamiliar to them, which actually may have other connotations and it's unclear. So I think be careful, stick with language which makes sense to patients, check out what it means to men, and don't feel we have to be pushed into using a word which does actually have some very negative connotations. That's what I'd say, with care, great care.
I think it seems like the majority of people here don't necessarily use the word, but from the charity, the bottom line is the side effects of hormone therapy, like any treatment, need to be explained, and it's possible to give an accurate description of someone's, potentially not scientifically accurate, but an almost accurate description of someone's prostate cancer and their treatment without using the correct medical definition of a word like castration.
Possibly a third comment, really nothing else to that. Thank you.
So thank you very much to Mike, Sarah and Emma for our discussion this morning. We've run over a little bit late, so is it all right if we come back at 11:35?
Absolutely fine.